Imagine you have a 9-year-old boy, and from the past 2 years, this 9-year-old boy keeps making weird noises in the class, gurgling, throat clearing, gurgling noises in the class. He keeps randomly blinking his eyes for no reason, keeps shrugging his shoulders repeatedly for no reason, and you can see in the picture that his friends in the class, they make fun of him. His teacher in the class is angry at him. The parent of this child brings this child to you, the doctor. He tells the parent is frustrated. He tells that this child of mine, he keeps making these noises and he keeps twitching all the time, and whatever we do, he doesn't seem to stop. What is this? This, my dear friend, is Tourette syndrome. Tourette syndrome is a neurodevelopmental disorder, and this is high yield, especially for USMLE. Basically, you should know the difference between Tourette and some other neurodevelopmental disorders like ADHD, OCD, etc. So don't worry, we'll do everything from the basic today. First of all, let's define this syndrome. Like I told you, it is a neurodevelopmental disorder. It is characterized by multiple motor and at least one vocal tic. This is very important. Now, if you may be wondering what is a tic, don't worry, I'll explain it in just a second. But remember that for the diagnosis of Tourette syndrome, you need at least one vocal tic along with multiple motor tics, and the duration of symptoms should be more than 1 year. It means that if somebody is having tics, a child is having tics, he keeps shrugging his shoulders repeatedly, making weird faces, but the question says or the patient says that this is for 6 months, then don't do this diagnosis of Tourette. Okay, don't do the diagnosis of Tourette. For doing the diagnosis of Tourette, you need at least 1 year of symptoms, and the onset of symptoms should be less than 18 years. It means that this is a disorder that is diagnosed in the children. Okay. Now, I told you I will first discuss what exactly is a tic. See, tics are sudden, rapid, recurrent, non-rhythmic movements or vocalizations. It could be vocalization also, that he has a suddenly the patient makes some weird sounds, sniffing sounds, this kind of sounds, throat clearing sounds. So these are vocal tics. If it is a vocal, it's called as a vocal tic. If it's sound, it's called vocal tic. At least one vocal tic should be there, minimum one vocal tic should be there. Along with that, multiple motor tics should be there. Okay, so remember, at least two motor tics and one vocal tics. Now, what are motor tics? They can be eye blinking, it can be facial grimacing, which means making these contracting your facial muscles, and shoulder shrugging, head jerking. Now, all of this, remember that all of these are sudden, rapid, recurrent, non-rhythmic movements. ठीक है. If a movement is rhythmic movements, if I tell you that rhythmic movements, the thing that should come to your mind is tremor. If and remember one thing I have not written over here, that these movements are not sustained. Okay, not sustained. If the movement is sustained movement, the thing that should come to your mind is dystonia. Okay. Another thing which is very common in the media is one vocal tic is called as coprolalia. What is coprolalia? Coprolalia just means using curse words. Okay, it just means using curse words. Randomly this person may curse, randomly he may say, use the F word, he may use other words which are not supposed to be used on YouTube, I think so. So one myth which is this myth is created by the media, by the movies, is that in Tourette syndrome, the patient curses a lot. He has coprolalia. But coprolalia is actually in a very small minority of the patients. Okay. And coprolalia is not required for the diagnosis. If you are a medical student, movies, if you are watching movies and social media and stuff, they confuse you and they make you think that coprolalia is present in every patient of Tourette, but it's only in a very small rare minority of Tourette syndrome. ठीक है. Again, diagnostic criteria: two motor tics, one vocal tic, duration more than 1 year, and the course of this is a waxing and waning. It means it goes up and down. All of these conditions must be met for the diagnosis. Other thing is that you should first rule out any substance abuse. You should first rule out any substance abuse, and you should also rule out other psychiatric conditions. Okay, only then you make this diagnosis of Tourette syndrome. One thing is that students tend to get confused between Tourette and OCD. Remember one thing, you can clear this confusion of Tourette and OCD by understanding something called as the premonitory urge. What is a premonitory urge? Premonitory urge is that the patient, before performing the tic, suppose if I am the patient who is having the a type of tic of shoulder shrugging. Now I like to shrug my shoulders randomly without any reason. I have this tic of shrugging my shoulders. Okay, so why do I do it? I do it because I feel that there is some bodily tension within me. Okay, so remember that I am talking about a bodily sensation. I feel some bodily sensation is happening within me. I feel a bodily tension is within me, and this tension, to relieve that tension, I perform this tick. And after performing this tick, I feel that tension is going down. Now, what do I feel? I feel a bodily tension. It is a bodily tension. Whereas in OCD, the person performs whatever his compulsion is. He performs that compulsion by a thought. Okay, by a thought that I need to go and check whether the door is locked or not. I need to go and check whether the gas stove is off or not. So the primary driving force is a thought, not a bodily sensation. Whereas in Tourette, the primary driving force is a bodily sensation. In OCD, the primary driving force is a thought, or it could be anxiety. Basically, the primary driving force is at the level of mind. Now, what is the pathophysiology or the neuroanatomy at play? The circuit which is responsible is cortico-striato-thalamo-cortical circuit. ठीक है, तो अभी थोड़ा सा this becomes very complicated. What I like to tell students so that they understand in a simple manner is that remember that in Tourette syndrome there is excess of dopamine in the basal ganglia, increased dopamine in the basal ganglia. And what are the basal ganglias? Remember that basal ganglias are more like the brakes of the nervous system. I'll explain it to you in a much more better way. Remember that the basal ganglia are like the brakes. You know, car is having a brake, B-R-A-K-E, brake. So just like car is having a brake, they are a brake of the nervous system and they are brake of the movement, which means that anytime in the basal ganglia, if there is lot of dopamine, there is going to be lot of movement. So if in the basal ganglia there is a lot of dopamine, okay, D is for dopamine, there is going to be a lot of movement, which is what exactly happens in Tourette syndrome or Tourette syndrome. Now, what will happen if there is less dopamine? in the basal ganglia. If there is less dopamine in that basal ganglia, there is going to be less movement. Where does this happen? If you know it, you know it. This happens in Parkinsonism. ठीक है. Again, Tourette syndrome, increase in dopamine in the basal ganglia. Parkinsonism, decrease in dopamine in the basal ganglia. Tourette syndrome, neurodevelopmental disorder. Parkinsonism, neurodegenerative disorder. ठीक है. This basic you should know. Okay, so we were here, we were discussing the neuropathology of Tourette syndrome. I told you there is an increase in dopamine in the basal ganglia, and because of this increase in dopamine, there is lot of unnecessary movements, more movement than needed. Okay, so one thing is that there is also genetic predisposition to Tourette syndrome. Remember that this is a neurodevelopmental disorder, and like all neurodevelopmental disorder, this disorder also decreases in severity with increase in age. What are the differentials? Differential is provisional tic disorder if the duration is less than 1 year. A persistent motor tic disorder if there are only motor tics, no vocal tics. Now I told you, very important for diagnosis, and this is where the USMLE they like to confuse you. This is where the USMLE likes to confuse the students, that in the question they will give only motor tics, and in the option they, one of the diagnosis they are going to write Tourette. So don't choose Tourette over here. Okay, choose motor tic, persistent motor tic disorder only. Choose Tourette only when they give you at least one vocal tic, which means at least one weird noise he is making, he is repeating words, or he is swearing, he is making some gurgling noises. All of that if they give, then you choose Tourette. You need to differentiate between OCD and Tourette. How do you differentiate? Like I already told you, in cases of OCD, the primary driving force is a thought. It is basically an anxiety. The thought comes to mind that if I don't go and close the door, someone is going to enter. So that is a thought entering my mind. Whereas in Tourette, I have tension building up in me. I don't have any thought. I have just some bodily tension, some stiffness or some pain building up in me, and I feel that pain will get relieved if I do some weird movements or some facial expression. So that is the primary differentiating feature between OCD and Tourette. Stereotypical movement disorder diagnosis when there are rhythmic movements. Okay, in Tourette these are non-rhythmic. Again you need to separate, differentiate between seizures and Tourette also. That you can do by seeing at the overall clinical picture. Some comorbidities clinically, Tourette can also be present with OCD and ADHD also. And when these comorbidities are present, for example, a patient has ADHD or OCD along with Tourette, that causes more functional impairment. Tics by themselves, one or two tics by themselves, or two tics, one vocal tic also, slight symptoms, they may not cause that much of functional impairment. Okay, so when it is present, when Tourette is present with other psychiatric things, then there is more functional impairment. Now coming to how do you manage? If the symptoms are mild, you only do reassurance, you only do psychoeducation. What is psychoeducation? Here you educate the parents, you educate the patient also that this is the problem which you are suffering from. So don't feel guilty about it. First of all, remove the extra depression, the guilt, whatever is there in the patient, and you educate the parent, you educate even the teachers, and you keep monitoring. So no pharmacotherapy is required. Okay, no cognitive behavior therapy is required if the case is mild. But if there is some level of functional impairment, you first go for CBT, which is cognitive behavioral therapy, and habit reversal. No pharmacotherapy. Okay, pharmacotherapy is only for high functional impairment. ठीक है, pharmacotherapy is only for high functional impairment. What is the pharmacotherapy? Let us discuss that. We can use the antipsychotics What do antipsychotics do? Antipsychotics decrease the dopamine, so all the extra dopamine that is there in the basal ganglia is going to go down, and they help for severe tic reduction. Okay. And alpha 2 agonist are effective if he has ADHD comorbidity. Generally in the exams, when they give you the symptoms, uh, NBME, USMLE type exams, they're going to give you a big stem that this patient is suffering from so and so. They are not going to tell you the diagnosis, they are going to give you the symptoms and the examination, and they are going to ask for the pharmacotherapy. And generally in the pharmacotherapy, they won't confuse you, they won't give you antipsychotics in the option, but clonidine will be there in the option, or this other drug will be there in the option. So generally they give clonidine, and along with it they give other classes of drugs which are not related. So here they test that you need to pick clonidine. Now, what is the legal and social context? The legal context is that these children are generally they generally are bullied in the class. They suffer from social isolation. Even their teachers, many times, if the teacher is not educated enough, the teacher may punish such childs. Many times, if there is coprolalia or echolalia, vocal tics, vocal tics may be seen as defiance. Okay. There can be some disciplinary action by the school on, or disciplinary action by the parents. So therefore education of the teachers also is important, that these are involuntary neurological phenomena. This is not something that the child is doing voluntarily. Again, let us discuss some high yield. Tourette should have both motor and vocal tics. Timeline duration should be more than 1 year, and there is a bodily tension, premonitory urge. There is a bodily tension, and the tension gets relieved by these tics. Another thing which I didn't tell in the tell previously is that the patient may have control over this tick. So tell you in the exam stem that patient is in the examination room, you are the doctor, you are examining, and there is no ticks during your examination. So this does not mean that there is no ticks during your examination. This does not mean that he does not have Tourette. So the patient can briefly suppress this, he can control this ticks for some time, and when he goes home, when nobody is seeing him, he may exhibit this ticks, and ticks gets worse with stress, and they are gone with sleep. One memory tick is that Tourette talks and twitches. Okay, so he talks. There is vocal tics, very important. This is where exam like to confuse. They will only give motor tics, and if they only give motor tics, your diagnosis should go towards persistent motor tic disorder. So Tourette, he talks, which means that he has vocal tics, and he twitches, which means he has motor tics, and he talks and twitches together for more than 1 year. So Tourette talks and twitches together for more than 1 year. This is how you should remember it, so that you don't get confused in the exams.